Hello all, this is Dr. Bernard Morey. I'm the Chief Medical Officer for Tenex, and first of all, I want to express our appreciation for you giving up your evening to hear of some of the advances that have been made with this technology. We're very pleased to introduce our presenter, Dr. Raul Desai, who will present on primarily focusing on calcific bone removal around the shoulder, but also in other areas. Dr. Desai is a musculoskeletal radiologist. He's an expert in interventional radiology and is involved in interventional joint and spine medicine. He's a founder of the practice, which is called RestorePDX. He's from around Portland, Beaverton, Oregon. He's also the president-elect and current vice president of Interventional Orthopedic Foundation. He's got a great depth and breadth of experience with Tenex, and we're very excited to have him share his insights and experience. But a few housekeeping concepts or ideas before we get started. There's a lot of participants, and we'll be muting all the phone lines during the webinar. So if you have any questions, and we anticipate them, please, during the presentation, jot them down. They will appear, and we will try to aggregate and then answer all the questions that we possibly can. And if for some reason or other we run out of time, please contact Tenex Health with your questions, and we'll try to answer any that may not have been answered on the webinar. So with that, I'll turn it over to Dr. Desai. Raul, thank you so much for your time and for sharing your expertise.
Thanks, Dr. Morey, and want to thank the Tenex team for helping put this together. And again, also thanks everybody for coming in and spending your evening. Hopefully, I can impart some of my experience, kind of like my show and tell, about rotator cuff, calcific tendinitis, and Tenex percutaneous tenotomy. Have a breadth of experience in other areas as well. So, if there are questions at the end, we've treated, from shoulder, rotator cuff to, the elbow, medial lateral epicondyle, moving down to the hip, the, gluteal insertional tendons, and the knee, quad, some really cool quadriceps tendinopathy, patellar tendinopathy cases, and down in the foot and ankle, Achilles and plantar fasciitis, and even fibromatosis. So Tenex has been a boon to our practice. I have no disclosures to make. I speak for Tenex right now just as an advocate of the technology. Also, I am, like Dr. Morey kindly introduced me, involved in the Interventional Orthopedic Foundation. And it's really a hub. It's a nonprofit, one of the largest nonprofits out there in this space. And I would urge you all to take a look at the website. Membership is crucial. We are non-biased. It's kind of a non-denominational regenerative medicine organization. Dr. Jared Malanga, who used to be former president of AAPM&R, is the current president, and I'm vice president, president-elect for next year. We want to grow the organization, and the foundational pieces are just to get this type of medicine out there, and we call it interventional orthopedics because it's not just regenerative medicine. It's tools like, or when we consider regenerative medicine just as PRP and biologics, it's not just that. It's some other interventional orthopedics, like a percutaneous carpal tunnel release and also percutaneous tenotomy. And what we're doing here with demonstrating Tenex tonight, there are all of these institutions receive scholarships for their residents and fellows to come and learn. And it's a grassroots program. I hope everybody can get involved. I want to also thank my family for letting me stay at work late tonight, and my wife for taking care of all these kids at home. And so thank you. Hopefully they can watch later. So we're going to talk about rotator cuff, and the problem is the most common source of shoulder pain. 30% of the adult population. It's a spectrum of disease ranging from a tendinopathy, tendinosis. What we're going to focus on is kind of calcific tendinitis, partial thickness tears. Full thickness tears is getting out of our control here, and then retracted full thickness tears, and then atrophied tears. So the risk factors, some things unfortunately we can't control. Age is always moving, right? Time is something that we can't stop. But there are things, and I would be remiss not to talk to you about those, that we can change. And so when we get into the regenerative medicine realm and those that are less experienced, I think something that's really important to look at is the overall picture, right? We want to see the forest from the trees, and we got to talk to these patients about other things, their adiposity, overweight, metabolic disorders, and then also kind of the more mechanical things, muscle imbalances, decreased flexibility, repetitive arm motion. I like this chart. We have the reference below. It kind of breaks down the difference between extrinsic or mechanical issues that will cause rotator cuff pathology, but also the intrinsic mechanisms. And part of this is that metabolic syndrome. And so we focus on, in our practice, when we're trying to help people heal, we want to make sure that we attend to those other things as well, that we can make, I always tell the patients I'm the guy that puts the fires out, but we need to take care of the entire system. And so we have help with our other practitioners. So part of regenerative medicine and part of when you use Tenex is really stratification of your patients. And so we're going to, we have grading of tendinosis from a healthy tendon to a grade 1, 2, 3, and 4, and that's a progressive pathway. And so where we see the regenerative medicine and Tenex in particular, the percutaneous tenotomy, helping is from anywhere from that grade 1 to an early grade 4, where there's not large defects. And especially if you start to get into, say, like an atrophic tendinopathy where there's not much tissue, then you may want to reconsider using the Tenex device, because it will cause some trauma to those few strands that are remaining, and then we may want a more regenerative approach to try to build some tissue. If you have a more prolific tendinopathy where there's a lot of hypertrophy, then Tenex is beautiful. So one of the analogies I'd like to use for my patients is to talk to them about the normal tendon. So you go to Home Depot and you buy a brand new rope. That's like your new healthy, your young healthy tendon. The tight twine, those are the type 1 collagen fibers. And unfortunately, as we age or if you have injuries, it's not a clean cut. That's not what the tear looks like. The tear is a breakdown of those fibers, and you get this fuzzy rope, and that's what that tendinopathic tendon looks like. So what are we trying to do is we're trying to take that tendinopathic tendon and reverse engineer and try to get that brand new rope appearance. And for those that are not really involved or early in their experience in regenerative medicine, there is a little bit of a leap of faith, and I hope that I can describe that and show that to you tonight, that this actually can occur. And then on top of this, kind of the analogy expanded is that if you have calcium in there, I like food and like to eat too much, but having that M&M and the chocolate in there, right? We're trying to get out the chocolate so that the tendon can heal. The traditional mechanisms with which we've treated tendinopathies include physiotherapy, medications, NSAIDs, narcotics, pain relievers, sometimes alternative medicine therapies, and then unfortunately steroid injections, and then surgery. And I really think that what we've seen and I've used all of these over the past 10, 12 years that I've been in practice out of fellowship, and nothing has improved the outcome for our patients compared to what we're doing now with the interventional orthopedics. We've gotten better and better. And, part of, this expansive tool set is the Tenex procedure and the percutaneous tenotomy, and I've really been very pleased with it. And so that sits in this interventional orthopedic realm, and then, with the regenerative medicine, it's kind of synergistic. And we're seeing more and more of this, and I think that it includes surgery. So, I have partners that are surgeons. I work in a surgery center, and it's an inclusive process. I think that there are different things that we stratify patients in, and not one size fits all. And the more tools that you have in your tool set, the better outcomes you're going to have for your patients. The Tenex debridement, what I liken it to is trying to do trying to rebuild a house. And, if you try to rebuild a house on the house, with the house still standing on the left, it's really, really difficult, right? And so that's what we had been relegated to. We had supratendinopathic tissue in a rotator cuff, and we would treat it with PRP or treat it with regenerative medicine therapies, and it would heal, but it would take a long time. There's fibroblast and macrophage activation, but your cells, like little Pac-Man and Pac-Man, had to clean up all this mess, and it took a long time. So sometimes you're doing 2, 3, 4 treatments, and sometimes it just wouldn't work. You have fibrotic tissue, and you just don't get any vascularity to the area. It would be a lot easier to heal if we started with this right-sided picture, and so that's kind of the Tenex debridement. This is a video that I'm going to show of kind of the old school calcium lavage aspiration, so 18-gauge needle into a large calcium deposit. And you can see puffs of cloudiness coming into the syringe, and that's the calcium that I'm washing out. So this is a very manual technique, but it was pretty darn effective. We started to use less and less steroid with this, but you can see how cloudy the syringe is getting, and it started out very clear. This is an example of this type of technique, and here's a large calcium deposit. This is a non-shadowing, so you can see all the way through it. This is in the rotator cuff, and you can see the needle that's going to enter, and this is placed directly into here. The next video, so I'm kind of futzing around here, so should have probably accessed that a little bit more easily. But the next video shows that this needle in the calcium, and you can see that I put suction on the syringe, and through here you're getting this toothpaste-like material, and it can be very effective in debulking the calcium. And you can see here, this is after the needle's in there, and we're washing. I'm trying to wash out as much of the chocolate out of the M&M as possible, right? And so this is within the rotator cuff tendon. You see deltoid musculature here. So that's an intratendinous lesion. This was one of the problems I encountered, was my thumb hurt because it was a manual technique. And so, sometimes, they would set up, my schedulers would put 2, 3, 4 in a row, and I would come out of there and just dreading my CMC arthritis. And over several years ago, we were luckily introduced to Tenex, which automated this process and did a lot better job. The other part of this that the Tenex does is that it takes away the penumbra of that dead and diseased tissue. So not only, when we get into the calcium deposit, such as this, the rim of the calcium is still left, and you can see here that as we're washing, you have this penumbra of tissue. Now the adjacent tissue is probably not super healthy either, and that's something that I feel like the Tenex does a really good job with. This is the setup that we have, so definitely like ergonomics is really important. Have needle pointing towards the screen. We have a nice setup, sterile field, and we're able to do that. The Tenex makes a particular specific noise. I'm going to turn it on here. Hopefully you guys can hear that, but this is after I'm stepping on the foot pedal. It kind of sounds like a dentist drill, right? And so that's what we're going to do. And so there I'm in a large calcium deposit. This is a zoom up on the screen of the ultrasound, and you can see here, those are the vibrational shadows here, and here's the needle device going through that tendon. And so that's an intratendinous. That whole thing right there is the calcium deposit. It's shadowing. You can't see the humeral head. It's within the tendon, and there's some fluid within the bursa. This is the MR imaging of this calcium deposit. So a pretty huge calcium deposit right at the supraspinatus insertion. And so you can see the needle passing through here. And as this passes through over time, this calcium, which was dense and mineralized and shadowing, is going to get less so, and you're going to start to see through it. You'll start to see within it, and then you're going to start to see the outline of the humerus. And that's the aspirate that we obtained from that patient, which is going to have a combination of the calcium, probably some dead and necrotic, fibrotic tendon tissue, and then here a little bit of blood. And bleeding in that tissue is not a terrible thing. This is a video. Let me mute this here. This is just a video of the before and after. So this is an MRI. I'm going to scroll through this same patient. And as we move through, you can see that there's some tendon disease, some tenosynovitis. And then as we move back, you're going to see that large calcium deposit. There's some intersubstance degeneration. And the calcium is intratendinous. So it's extending into the bursa, but most of it is within the tendon. Post-treatment with the Tenex, you can see this is the after MRI. Still a bit of tenosynovitis, but kind of pay attention to the tendon. It's starting to look really good, and the calcium is gone. This is several weeks later. Patient is doing tremendously well, and the calcium's gone. The tendon has a little bit of intersubstance signal still, but over time, with proper rehab, a tincture of time, and sometimes synergistic therapy, we're going to see that improves. The synergistic therapy, what I really like to do, and we're working on an internal study of patients, is to do the Tenex debridement followed by regenerative medicine therapy, right? So doing the demo and then having the remodel turbocharged. And so the concept is that the Tenex is going to deliver that ultrasonic energy at the microtip, and we'll talk a little bit about that, cut the dead and diseased tissue, and in this case the calcium, while sparing the healthy tissue. And so this is what it's doing. It's going to turbocharge the healing, right? So you have this house that's really decrepit. We need to get rid of it. Tenex debridement, we're starting with a fresh field. And there's a chance that goes to healing by itself. But using the synergistic therapies, I feel like we have a better chance of getting this, beautiful new home and the remodel and that new tendon. This was a case, again, we're going to talk about mostly shoulder, but I think this is a really nice depiction of what the synergistic therapy can do. Gentleman came to see us, had been a pretty active, healthy gentleman, was even a marathon runner, had 18 months ago was running and started to have severe pain, and ran through the end of the marathon, but over the past 18 months started to get worse and worse and worse. He saw me 18 months post the beginning of this pain, and he came in last 3 months riding in a wheelchair. The worst Achilles tendinopathy that I'd seen. It was hard and fibrotic. The skin was indurated. There's a lot of kind of myxoid fibrotic tissue. This was the ultrasound appearance of the tissue. We did a Tenex procedure. I made it, to debride it. So we did a combination Tenex and stem cell therapy. We made 5 separate incisions along the length of the tendon, and then debrided it. It was kind of like a big, sausage, and we were just going to go, up and down and top to bottom and clean out all of this dead and diseased tissue. We had 20 minutes of cutting time, and then we had harvested stem cells, bone marrow, fat, PRP, and then injected that into it. He called me 6 weeks afterwards, completely pain-free. He called me 3 months afterwards and wanted to run again. And he was from New York City. We asked him he lived across the street from HSS, where this original MRI was done. So we told him, go back and send me an image. And when he sent it back, we looked at it, and I thought we had the wrong patient. I was absolutely astounded at what happened in 3 months. And this is that after picture. And you can see this horrible tendinopathic tendon, and one that is, while a little bit thickened, completely void of signal and looks like a very healthy and strong tendon, and the patient's pain-free. So I really believe I haven't seen this with either therapy by itself. So I think there's some powerful synergy that's occurring. These are the axials and another slice through that tendon. So what's the Tenex actually doing? Right? And so it's removing the degenerative tissue and lessening the impact of the stage of the disease. And so at the microtip, there's a lot going on. So this is vibrating back and forth at 26 megahertz. It's preferentially breaking down dead, diseased, fibrotic tendon. And through this outer cannula, you're getting an irrigation, and then through the inner cannula, you're getting an aspiration. So not only are you breaking down the calcium, you're breaking down dead and diseased tissue, but you're removing it. We have more access to different types of tips. So the TX1 tip is a little bit shorter, right? So the length is about 2.5 centimeters. And the TX2 material is a little bit different with stainless steel. It seems a little bit more robust, 4.3 centimeters. And that's allowed access to larger patients, to deeper structures, especially when you're getting into like the gluteal tendons. I forgot to mention that we've done some hamstring origin tendinopathies with some good success. And this, depending on the patient's body habitus, obviously they have to be, for those areas, they have to be relatively slim to access that. But this TX2 needle is going to provide that. Now the TX Plus or TX Bone is out, and this is even a more robust needle, and it's going to be able to debride bone. I have a demo which I've not been able to use, but I've used this at a IOF course this February, and it was pretty amazing how well it cut through bone. So that's something that those indications are there. We see, enthesopathic heterotopic ossification, and I'm excited to get to use this. But here's a guide so you guys can go back and take a look at this. So in the interventional orthopedic regenerative therapy model, I think the important things that we need to look at so we are all successful and have happy patients and really allow this medicine to progress is the proper indication. I think stratification is super important, and we're going to, as time goes and studies come out, that's something that we're going to get better and better at. I am completely biased and think that diagnosis is paramount, obviously using ultrasound, MRI, CT, X-rays, whatever we need to, physical examination. And we're going to have to differentiate those things from partial tendinosis, partial thickness tears, full thickness tears. Even small full thickness tears, is the rotator cable intact, and can it work as a scaffold? And then full thickness tears with retraction obviously may not be, we need to send that to the surgeon. So we're really focusing on these, grade 2, even grade 1 to early grade 4. And I think we can augment, and I think there's a really nice place for regenerative medicine. Is it going to replace surgery? No. But is it going to work as a wonderful bridge between what we've traditionally done and what I think we should probably stay away from a lot of times, steroid injections? Yes. And so for those that haven't used this a lot and have not seen, so I've been doing regenerative medicine for about 10 years, got lucky, started in 2008, and we started to treat patients. I really didn't believe in the medicine, but I thought, hey, I'm good at diagnosing, we're good at putting a needle into a spot. And we used this medicine, and I was shocked patients came back, they were feeling better, and I really didn't believe them. So I said, okay, let's get back on the MRI scanner. I have a partial thickness tear. Jump back on there and let's see what's happening with it. And lo and behold, it was healed. And we saw this over and over. And it took about 20, 30 patients for me to truly believe. It's been 10 years and about 4,000 patients later. And so the kind of that leap of faith, and hopefully it's not a leap of faith, that it becomes proven, it's all magic before it's science. And so I think that we're showing that this is actually, working really well and going from these like partial thickness tears or tendinopathy to new tendon. And so what we can treat well with the Tenex is tendinosis, this hypertrophic tendinopathy. You can see increased signal in the MRI, and then hypoechogenicity and increased thickness on the ultrasound. These partial thickness tears where there's maybe a penumbra of tendinopathic tissue. You can see these little enthesopathic bony changes there, a good candidate. Obviously, calcific tendinitis, great candidate. Debulk that tissue, allow that tendon to heal, right? And full thickness tears, not so much, right? I mean, if it's non-retracted, less than 8 millimeters, maybe we can talk about a stem cell with fat and kind of a scaffolding. But again, what's the status of the rotator cable? And so, obviously, I don't think this is the role for tonight's discussion. This is a representative case, imaging 57-year-old female. When you see this type of calcium, which is very different than what we saw before on the video, where it was echogenic and you could see through it, this is very dense and hard mineralized calcium. Right? And so you can see here, it's densely shadowing. We treated this patient, debrided it, and you can see here, now it's non-shadowing. We got a lot of that calcium to go away, but there was still quite a bit left. And so this was post-Tenex, and you can see here that this is something that we need to still treat. They were feeling better, but not fully resolved. We did a regenerative medicine therapy into that. So that's what it looked like before, right? So shadowing. Now, much less dense, much less mineralized, but this is still not healthy tendon. You can see that we're seeing the interface of bone here, and we have lost that initially. So we did a regenerative medicine therapy. Several weeks later, we're at 8 weeks, and you can see very little calcium remaining versus still slightly thickened. Not perfect, but heading in that direction where we're getting this new native type tendon to come into play. Now this is out even a few weeks later, and you can see that this looks near perfect and normal. And so that's the progression of the pathology and pathway towards healing. Now, again, adjunctively, physical therapy is very important. I'm a big believer in eccentric loading, getting blood flow to the area and allowing for healing. My analogy to the patients is, when you work out, you build muscle. You put it through stress, the body responds and builds it stronger, and the same thing happens in tendons. It just takes a little bit longer, but that's what we're seeing. So we're seeing at 7 months and 11 months, virtual complete healing. This is another case, 59-year-old male, where this is pretty atrophic. I probably wouldn't use Tenex in this case, right? You got a small partial thickness tear, the tendon's atrophic. I would be afraid of, not from the Tenex itself, because the Tenex is very safe as far as breaking down healthy tissue, but simply from the needle and the trauma to the area. We can see here that we're starting to allow that tendon to heal and build. And I think that's where the regenerative therapy comes in. This was a combination therapy, a separate patient with a small full thickness non-retracted tear, part of the rotator cable. Something that if anybody's interested in, they can ask me. I have some interesting literature on that. But it's holding the tendon, the supraspinatus intact. We filled this in. I call this the gamush phase. So this is a couple months later, patient's feeling a lot better, but it doesn't look great, right? But there's something happening, something filling in here, and there's this disorganized tissue. When we use those eccentrics for a patient that was actually doing a lot better here, when we use the physical therapy, the eccentrics, the loading, this is a year later where we have neotendon. Does it look perfect? No. Is the patient pain-free? Yes. We have neotendon formation? Yeah. And the patient's doing really well. So that's that progression of healing. This was a patient that we had treated, and this was before I'd used Tenex. This would have been an ideal patient for Tenex percutaneous tenotomy. Multi-fragmented calcific tendinitis, bursitis, thickened tendon, and then just kind of, some holes. It was that frayed rope. We did the therapy. It took me 2 or 3 rounds of regenerative medicine therapy, but we were actually able to get it to go from that frayed degenerative rope to basically a native-looking tendon. This was a professional drummer that did really well. And so that's kind of that analogy reiterated. This is my, kind of bringing things together. I have a 3-legged stool for successful regenerative medicine. So, and I really consider Tenex a regenerative therapy. It's in the interventional orthopedic realm, but what are we trying to do? We're affecting tissue, taking out the degenerative, fibrotic, scarred, broken down tendinopathic tissue, and allowing the body to heal and replace it with native tissue, and taking away the dysfunction and the symptoms that have been hindering the patient's activity. And so what are the 3 main legs of the stool? Or precision diagnosis, so from history, physical examination, diagnostic imaging, and sometimes these diagnostic injections. We do a lot of injections with anesthetic, with low-dose prolotherapies to make sure, especially when we're working with spine and hip, to make sure we're in the right areas. Precision biologics, I think we sometimes focus a little bit too much on this, but I think it's important. Obviously, it's going to be a progressive industry as we look at all these different possibilities that are out there, and it's super exciting. But again, if you don't have all 3 of these legs, things are going to fall down. And then precision delivery, right? I'm a little bit biased, but we definitely need image guidance, whether it be ultrasound, fluoroscopy, even MR-guided therapies are present. So that's something that's important. And then also the rehabilitation and looking at the entire system, nutrition, sleep, those foundational pieces. But for the things that we can mostly augment as practitioners, these are the 3 things that I think we should focus on. Future considerations, multiple treatments. Sometimes it's not a one and done, and that's okay. And have that conversation early on with patients. Say, hey, we can heal you, but it may take me 1, 2, or 3 treatments. And differentiating or stratifying patients that are on a curative course versus a maintenance, right? So that's something that I think is really important. That when somebody comes in and they have a calcific tendinitis, they have a rotator cuff or a tendon pathology or plantar fasciitis, I talk to them. I said, look, we want to cure this. We can fix this. It may take me a couple of rounds. You have to be patient with us, but we can get this better. When somebody comes in with in the regenerative medicine realms, a KL3 or severe arthritis, then we got to switch that conversation to a maintenance. I can give you a high quality of life and get you functional, but if you have enough birthdays and you're active enough, you're going to be back, right? And so that's the clear and concise message that we try to get across to our patients. Combination therapies are going to be exciting, right? So PRP, amniotic membrane, all the different types of stuff that's coming out. Stem cells, both autologous and potentially allogeneic in the future. Surgery plus therapies, so for like shoulder and surgical debridement, a decompression, if they have a type 3, acromion, or they're having some major mechanical issues, we might be able to heal the tendon, but if we don't take away that mechanical obstruction, they're just going to re-injure it. But then changing the biomechanics, so it's, it helps not injure the tendon further, and then using regenerative therapies. Strict dietary modifications. I'm actually on my day 3 of the Prolon, and I think it's been fabulous for our patients, reducing inflammation, helping with stem cell activation, using collagen supplements, laser therapies, class 4 laser with the future 1064 wavelength. I think is really exciting, something that can help tendon healing without having to poke a needle into somebody or to augment after you've done that if the patient needs further kind of activation, something that's exciting. And then biologically, metabolically enhancing clothing and wearables, something that we've been really interested in. So those are kind of the future considerations that are exciting in this field. So I wanted to keep it kind of short and sweet so we had some time for questions. And this is my email. If anybody's interested, please shoot me an email. I had the beautiful background pictures of Oregon. Our practice is growing. If there's anybody interested in joining us out here and building the practice, shoot me a line as well.